Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts.
Before we get into today's letters to the editor, let's cover the study that started this whole debate. The MOSAIC study was a prospective multi-center trial out of Japan, published in JVIR. 57 patients scheduled for transradial hepatic intervention were enrolled. 2 ended up going femoral instead, so 55 underwent transradial access. Of those 55 patients, 9 showed silent brain infarction on post-procedure MRI. That's 16.4%. All asymptomatic, no neurologic deficits, but still real infarcts on diffusion-weighted imaging. That's the data. Now here's where 2 letters to the editor push back on how the authors framed it. Let's get started.
We take transradial access for granted in the coronaries, right? But dropping down for visceral or hepatic interventions is, a different anatomical beast.
Oh, absolutely.
You are navigating the aortic arch, and in an older population, that arch is often loaded with calcified plaque.
And the possible cost of scraping that plaque, which was really highlighted in the recent MOSAIC study debate, is asymptomatic brain infarction.
Right.
It's an uncomfortable reality for anyone doing these procedures. So this recent letter to the editor exchange digs right into why this happens.
Exactly. So the core clinical question for our deep dive today is how we optimize transradial access for visceral interventions while minimizing embolic stroke risk. We need to look at patient selection, the actual technique, and where standard protocols might be failing us.
Well, the MOSAIC data forces us to look at age and anatomy first. 8 of the 9 patients who suffered silent strokes were over 70, with a mean age of 80.
Which makes sense.
Yeah, and the response letters propose a very practical algorithm. Basically, if they're over 70, require a pre-procedural chest CT. If you see significant eccentric plaque in the arch or supraaortic vessels, you just default to femoral.
See, I agree with going femoral there, but look at how the original authors framed their anatomical assessment. They put a lot of emphasis on the angulation of the left subclavian artery.
They did, yeah.
But does the angle even matter if the plaque is what's actually breaking off? A steep angle makes tracking difficult, sure, but it's the physical burden of calcification that embolizes, right? Not just the angle.
Right, and that is the precise blind spot the letters point out. An extreme left subclavian angle might increase friction, but if the arch is clean, the embolic risk is actually relatively low.
Exactly.
But if it's heavily diseased, even a mild angle becomes hazardous because of the procedural mechanics involved.
Which explains the stroke territories in the study. 7 of those 9 strokes hit areas unrelated to the left vertebral artery, places like the brachiocephalic territory.
Yeah, that tells us the emboli aren't just coming from the subclavian access site. They may be a direct result of prolonged manipulation in the arch itself.
Wait, how prolonged are we talking?
The data shows stroke cases average 9 minutes just to reach the descending aorta, compared to only 1 minute for non-stroke cases.
9 minutes of grinding against the arch wall. That means the standard practice of exchanging diagnostic catheters for pigtails in the arch should be carefully reconsidered. Every exchange is another pass over that plaque.
Yeah, the consensus here strongly favors using a microcatheter and micro-guidewire combination to get down safely, and relying on soft J-tip wires instead of angled hydrophilic ones.
Because those angled hydrophilic wires tend to subintimal track or slice through friable atheroma.
Precisely. But, technique is only half the equation. The pharmacology debate in these letters is equally intense. The MOSAIC group relied on ACT-guided heparin dosing, shooting for the 200 to 300 second range we typically use in neurointerventions.
But ACT is not always reliable in transradial cases. Between local arterial spasm, hemodilution from the sheath flesh, and compartmentalization in the arm.
Right, relying on peripheral samples may give us a falsely elevated sense of systemic anticoagulation.
It is possible to think they are therapeutic, but they are maybe under-heparinized.
Because the local radial environment may not reflect systemic clotting dynamics accurately, so the recommended alternative in the risk mitigation is a fixed interval protocol.
So ignoring ACT entirely?
Yeah, 3,000 to 5,000 IU up front, followed strictly by 1,000 IU every 30 minutes, completely ignoring the ACT.
Interesting. But the MOSAIC authors also tried to mitigate risk using a continuous saline flush to prevent pericatheter thrombus. I struggle to see the physiologic benefit there.
It addresses one potential mechanism, but probably not the primary one. The strokes aren't happening because of stagnant blood-forming clots on the catheter. They're likely happening because of mechanical shear forces scraping atheroma off the vessel wall.
And saline doesn't dissolve atheroma.
No, it doesn't. And that mechanical shear force ties into the operator experience limitation. A confounder in the MOSAIC data was that early career residents were scrubbing in on these complex transradial cases.
Ah, so that is the possible mechanism behind those prolonged arch times.
Exactly. It refines the current guidelines by making it clear that assessing the anatomy isn't enough. Complex arch anatomy must be paired with operator experience.
That makes perfect sense. The anatomy dictates the tool, but the operator dictates the time spent in the danger zone. If you are doing visceral interventions tomorrow, you might adopt a strict age-based cutoff, requiring a chest CT to rule out arch calcification in patients over 70 before attempting transradial access. A large-scale randomized trial comparing ACT-guided heparinization against a fixed 30-minute interval dosing protocol during visceral transradial access would help determine the optimal anticoagulation strategy. That's all for today. Thanks for listening.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.